Hello and welcome. My name is Danielle Farrell and I am a public education coordinator with the Alzheimer Society of Peel. And today's topic that I'll be discussing with you is dementia during COVID. So we know that there are quite a few diseases under the heading of dementia, and that these diseases actually have fairly lengthy disease courses. And as a result, the person living with dementia and their care partner will require a lot of support over the long journey. And although I won't discuss here the average length of all of the diseases that fall under the heading of dementia, I will talk about these ones here, which are the most, commonly diagnosed. So the most commonly diagnosed is Alzheimer's disease, accounting for somewhere between 60 and 70% of all of the diagnosis of dementia. So 4 to 11 years is the average, but there are people who have lived up to 20 years or longer with it. So there can certainly be exceptions to the rule, but somewhere between 4 to 11 years and 8 to 10 being more likely. But the younger the age of onset, the quicker the progression. And the later the age of onset, the slower the progression usually. And this doesn't matter which of the diseases here we're talking about. That is true as sort of an expectation of all of them, that the younger the age of onset, the quicker the progression would be. Lewy body dementia, which together with Parkinson's dementia accounts for about 20% of cases of dementia, or the cause of the dementia symptoms, and it has a 5 to 8 year average. And then frontal temporal lobe dementia, which in itself is an umbrella term, and there are 6 diseases that fall under the heading of frontal temporal lobe dementia, and those diseases together have an average of 7 to 9 years of the sort of the course of the disease from time of symptom onset to the time of passing. Vascular dementia, which, some people say is the second most common, some people say it's the third most common, and there's some debate about that in the numbers if you're looking at different studies. But in general, vascular dementia will range from anywhere from 5 to 10 years, and really depends on the type of vascular dementia the person has. So small vessel disease, large strokes, mini strokes known as transient ischemic attacks or TIAs, and also covert strokes, which are also small little strokes that might not be even noted when they're happening. But these things are causing the dementia symptoms, and really it depends on how many strokes the person's having and what regions of the brain. And so there can be a wide range, and there's certainly a lot of people like Alzheimer's disease who will live well past 10 years with vascular dementia. So there are some models that are used to describe the progression that a person will go through when they are diagnosed with one of these diseases of the brain. And so there's 2 models really that are sort of the standard. One is a 3-stage model and one is a 7-stage model. So the 3-stage model is often used for all diseases that are under the heading of dementia, but the 7-stage model is usually only applied when you're speaking about Alzheimer's disease or Lewy body dementia. So this is a little bit about how the models intersect. And so the 3-stage model, being fairly simple, is an early stage, a middle stage, and a late stage. And the 7-stage model is that their stage 2 and 3 would really be explaining an early stage. 4 and 5, it's really equaling what in the 3-stage model would be the mid stage or middle stage. And then we have stages 6 and 7 in the 7-stage model. And really that correlates to late stage of dementia. So a lot of people will ask us, what do the scores mean? So when someone has a mini mental status exam, or someone has the MOCA, which is also referred to as the Montreal Cognitive Assessment. These scores and the way the testing is done is to show where there are deficits in the brain, to show where damage is. And although the scores cannot directly tell you exactly where somebody is in the model stages, it gives a pretty good indicator. And what I mean by that is there's some ranges of the score out of 30 that will tell you or give you some idea of where the person is, but they may score quite low on one section and still be in the early stage. So that's why I can't exactly correlate, but it does give a pretty good indicator. So 26 out of 30 indicates a normal age-related change. 20 to 24 indicates that there is mild dementia present, so early stage. 13 to 19 of a score is more indicative that the person has moved into the mid or moderate stages of dementia. And then 12 and under score indicates that the person is in late stages of their disease process. When we start to get, sort of below that 5 and under, we're also looking at end stage or the terminal phase of the disease. So all these are terminal diseases, and so they do have a terminal phase. So the MMSE, the Mini Mental Status Exam, used to be used quite readily. It is still sometimes used when Alzheimer's disease might be, probable or suspected. But the MOCA is the one in the Montreal Cognitive Assessment is the test that is now an assessment that is more readily used, especially if they're not sure what disease might be causing the dementia symptoms, because it has been shown to pick up better some of the other deficits that a person living with dementia might be experiencing, especially if it isn't Alzheimer's disease. So in the stages of progression here, what sort of changes are sort of normal or expected at each sort of stage? So beyond just the scores on those assessments, what else would be an indicator or imply where they might be in the stages? So stage 1 is where the person appears still quite normal, and they're able to cover up the lapses because the functional issues they're having aren't happening all the time, not happening daily, and the person really is able to sort of excuse what's going on or some of the things they're having difficulty with, or they might note them but think, well, it hasn't happened again, so they tend to, ignore it. Stage 2 is where the person forgets certain things, so they start to have some memory issues, but otherwise they might be functioning quite well with some other tasks. It's just, memory has been affected. Stage 3, difficulties at work start to become an issue if they're still working. If they're not working, they may become more anxious. This is where they're starting to have enough impairment that family starts to notice that the person is functioning a little bit differently and starts to wonder, what could be going on. This is often at the end, kind of in this stage 3 where people usually search out or go looking for diagnostic and assessment to find out what might be happening. Stage 4, they have a reduced ability for managing finances, coming up with their own ways to manage their own affairs, whether they're financial or, getting to appointments and just really managing all of those things that we do daily. Maybe finding it difficult to travel now, so maybe getting lost when walking or getting lost when driving. Those kinds of things are starting to happen. Stage 5, there is a progression, and the person starts to have difficulty with things like getting dressed. For example, I would need assistance with some of those activities of daily living, like getting dressed. And then stage 6, we have further progression. The person is now needing help with things like going to the washroom. They may become incontinent by this stage, becoming very disorientated to what time it is, what place it is, what year, what season, those sorts of things. And at this stage, they would also start to forget or to not maybe recognize family members, and that sort of thing is starting to occur. And then in stage 7, we have, a lot of progression, and we have where there's speech impairment, there's motor impairment. Certainly there would be incontinence by this stage. The person will actually need help to eat and be completely disorientated really to their surroundings. So that's also a way, if families are asking you about what stage do you think the person's at, or how do I know what stage the person's at? So either the score on the MMSE or the MOCA, or some of these functional changes could be a pretty good indicator. So one of the things that a lot of people have been asking, especially since we've gone virtual in our COVID world now, is how to get a message across. How do we communicate with someone living with dementia in this virtual world? And so the interesting thing is that it doesn't change that much. We're not really doing a lot different than we've done before. And there are some techniques you use to communicate well with someone living with dementia, and really you're going to continue those, but in a virtual setting. So you still always want to introduce yourself. That's the first thing that you would do if you were interacting with someone living with dementia face-to-face. The same thing with virtual. You're introducing who you are and how the person knows you, or how you've been connected to the person. You set the stage, meaning you explain what you're going to be doing. So what the program is going to be. And then we want to speak slowly and clearly. And we have something in dementia called the 20-second rule. And really, it's a best practice for how to communicate with someone living with dementia. And so the 20-second rule means that we give somebody living with dementia 10 seconds to process the information we're providing, the instruction we gave, or the direction we gave, and then we wait 10 more seconds for the person to get out their messaging to us. So 10 seconds for them to process what we said, and 10 more seconds for them to be able to relay a message back. This is a very slow way of communicating. It's much slower than we're used to, but really it is a really good way for a person living with dementia to be able to take part in conversations, and so that we don't outpace them. We also want to make sure we give one message at a time, so not too much information at a time. And one of the other ways to look at this is to communicate with someone living with dementia as if there was a language barrier. So when we meet somebody who doesn't speak the same language as us, what we tend to do is we take out, excess words in a sentence, and we use the key phrases or the key words, and we use a lot of pointing, and we use a lot of gesturing in order to communicate. And that is something that, whether you're virtual or in person, if you're sticking to the 20/20 rule and you're communicating as if there's a language barrier and just giving small chunks of information and keywords, the person living with dementia is going to have an easier time conversing and taking part in that communication. The other thing that we always recommend when you're in person with someone living with dementia is that you would take care of some of the background distractions or noises and lower them, and control them the best you can, so the person living with dementia won't be overstimulated and can concentrate on what you're doing. So in a virtual setting, you want to do the same thing. You want to make sure that if they come into the program, it's a virtual program, and they've got their TV on in the background, and they've got the radio playing, or there's people in that household having conversations in the same room where the person living with dementia is trying to take part in the virtual setting, then, you know, asking those people to move away, or if the person living with dementia can move to a quiet room, or if the TV could be turned off. So just same thing, just directing and asking for some support around those background distractions to be removed. When we are working with someone living with dementia, we suggest that we get a message across by validating the emotional message, meaning that a person living with dementia may give you wrong information, incorrect information because of those brain changes. And, you know, what we want to realize is that whatever emotion is being expressed in that message, the emotion is very real to the person, even if the information they're giving isn't correct. So if they give you an answer that doesn't really match what you were asking, or doesn't match, you know, the program that you're doing, understand that the person is still trying to communicate with you, and whatever emotional message is there, try to grasp what that is, so you'll be able to communicate with the person better. Virtual or in person, we don't want to be arguing when somebody living with dementia doesn't give us quite the right info. And in person or virtual, we want to be asking questions that get the person talking about their past personal life experiences, because that long-term memory is often intact, although the short-term is affected, and we want them to be able to take part in the communication. So there's a couple of things that we should know about our nonverbal messaging. And these are the body language and things like that, that whether we're in person or whether we're in a virtual setting, people living with dementia, when they're starting to have difficulty not understanding the words we're using, they start to look at other factors. And often that's our body language, it's the tone of our voice, it's the pace that we're going at. So they start to look for other things to help them understand what is going on with the communication. So very important to keep a calm, relaxed appearance, so positive body language. So this is usually seen as a very closed body language, whereas the arms open are seen as a more receptive body language. So just keeping that in mind. If someone has a hearing impairment, we tend to really raise our voices, but sometimes that can come across to others in the group as aggressive. So we want to make sure that we keep a fairly, an upbeat tone, and that we don't rush anybody. And that was whether we're virtual or in person. So I have a little pair of binoculars here, and the reason for that is people living with Alzheimer's disease in particular, they start to lose their peripheral vision. And it's not because there's an eyesight change, it's actually the change in the brain. So the brain creates this scenario where they cannot make sense of what they're seeing in the peripheral. So the brain is kind of almost ignoring that. So whether we're virtual or in person, we want to make sure that the approach is directly on. And sometimes in a virtual setting, this is actually easier. But we want to make sure we're in this face-to-face direct eye contact, as opposed to approaching from the side, because people living with dementia, as the disease progresses, what they're able to be able to process from a visual perspective narrows until late stage. It is like this. So like a set of binoculars, if you make a set of binoculars, it's just whatever you see directly in front and nothing else. So that's really important to remember when we are working with them virtually, just asking the person to really look into where the camera is. So really look to where the little green dot is, so that they can be making better eye contact and be able to see. The other thing to note is that we say things with our body we don't mean to say sometimes. So I'd like everybody to make an okay sign with me with their hand, and I want you to touch your cheek. So I went chin, but I said cheek. So if you went chin with me, that is because what we do with our body and our body language is actually giving strong messages, and sometimes even stronger than the words we're actually using. So really important to keep that in mind when you're working with someone living with dementia, that the body language is being observed. So one of the things that we've been asked about a lot at the Alzheimer Society of Peel, and anybody who's working in the field and they're supporting persons living with dementia, and they don't live with the person living with dementia. So a lot of our care partners are asking staff, they're working in day programs, working in retirement homes, working in all kinds of different settings. I can't be there because of COVID, so how can I best support my mom, my dad, my brother, my sister, my spouse? So one of the things that can be done if the person living with dementia lives alone is meal delivery. So things like Meals on Wheels is still working right now, that kind of service. So that could be looked into. Med reminder calls. So either the family could be calling the person living with dementia to remind them to take their medication, and not just, okay, it's time to take your medication, gotta go now, bye. It's, okay, go get your medication, bring it over to the phone with some water, take your medication, did you just take your medication? Following through on that to ensure that medication is being taken. You could also involve neighbors. So maybe the person living with dementia has some neighbors, maybe they've lived there for a long time and they know the neighbors fairly well. So the neighbors, you could provide them with your phone number, and the care partner could provide the neighbor with the phone number, and then, they can check in. Have you seen, could you go do a quick check at the door, knock on the door? Just let me know that my family member was able to answer the door and that they said they were okay and they looked okay, that sort of thing. Home care agencies can still be hired at this time. So home care agencies are still sending in people to provide companionship, light housekeeping, meals, doing some meals, things like that. It might be financially not an option for some caregivers, but if it is an option, that might be something that could work. Locating devices like GPS systems, medical alert bracelets, vulnerable person registry with the local police. These are all things that could be set up and done to keep the person safer. So maybe without the family checking in as much, maybe the person living with dementia is at a higher risk of leaving the home and going missing. So we know 6 out of 10 people living with dementia will go missing at some point in their disease process. So it's important that the family does plan for those missing person incidents. And if they go to this website, www.findingyourwayontario.ca, there is a whole host of locating device ideas, safety planning, around a missing incident and how you can safety proof the house a bit for that. So that's something else that the person, the family members might be able to do for the person living with dementia, even though they don't live with them. Some of the other things they could do is look at a lifeline or another emergency response system. So those things right now are still available during COVID, so they could be set up still. Purchasing some auto shut-off appliances, things like the kettle and things like irons and things like that that could be very dangerous. Faucets can be installed that, they turn themselves off. So things of that nature could be installed. Something I know some caregivers, some care partners have done when they don't live with the person living with dementia, but they're getting concerned about how that person's functioning in their environment and how they're actually doing, have installed some nanny cams. So nanny cameras might be an option. Phones, you can get programmed phones that actually have a picture beside them of the family member. So if the person's having trouble remembering how to use a phone, a pre-programmed phone where they just push a picture, that goes to that particular family member and calls them can be quite helpful. One of the other options is to have the person with dementia sign a consent form so that their healthcare team can discuss anything with the care partner or POA. So what's happening right now during COVID is we have persons living with dementia that might be going to doctor's appointments, possibly in person. But what's happening is family members are asked not to come with or not to come in with, and this is to reduce risk for COVID. But unfortunately, with that memory impairment, sometimes that means how is the care partner going to know what was said or not said, and the person living with dementia may not be able to relay that information afterwards. So getting this consent form might be helpful. And that way the care partner can just get a report from the family doctor or from the specialist or whoever it was on whatever the recommendations made were, whatever the outcome was. Assisted supportive housing, if a person living with dementia lives in that type of environment, then a lot of the staff at these places are helping with FaceTime or Skype options so that the person living with dementia and the caregiver in the community are able to communicate in some sort of at least face options for communication in the virtual setting. So one of the other questions we've been getting a lot from care partners is, how does the care partner get a break during COVID if they do live with the person living with dementia? And so a lot of primary program workers in day programs, when they're speaking to the families, this is a question that they're getting a lot. So here's a few things that might help. So using headphones with music for the person living with dementia and or for the caregiver. So having the headphones on can be a distraction with music that the person living with dementia enjoys. So it could be any music they like. But that can keep the person a bit occupied while the care partner caregiver gets a little break within the home setting. If the person living with dementia doesn't enjoy headphones on, doesn't enjoy music, maybe the caregiver putting on headphones and listening to some music will drown out. They can still have their eyes on the person living with dementia, but they're able to kind of get a little distance mentally by having their own music on and headphones on. Having a space in the home with a lock, so a bedroom or a bathroom where they can go, the care partner can go to get a short break from the person living with dementia. So when they've kind of hit their patience level and they need some moments to themselves, they can go somewhere, lock the door for a little bit and, read for a few minutes, listen to some music for a few minutes, take, deep breathing exercise, but something to help calm. Have the person living with dementia do simple and yet time-consuming activities so that the care partner can walk away. A good example of this would be sorting activities. So the person is sitting sorting coins or sorting buttons, but they're doing something, polishing silverware, but they're doing something that takes a bit of time, but once the person gets in the rhythm of doing, the caregiver could walk away and safely do so. If you can't take the person living with dementia to the store, so you've got a care partner who's saying, I don't know what to do, I really can't take my family member to the stores anymore, but we got to get our shopping done, then they might be interested in there's so many services now with online shopping or delivery. And then the other option for the caregiver to get a break is to hire a home care agency. Yes, there is cost to it, I recognize, and so it won't be for everybody, but hiring a home care agency to come in to provide some respite so that the caregiver can go for a walk, just get out for a walk, take a cup of coffee or tea with them, or even go sit in their backyard and just get a break. So, there are some options there. So available resources during COVID. So some resources, yes, have been altered in the way that they can provide a service due to COVID. But currently, Etobicoke Services for Seniors has 2 respite beds they've opened for short stay respite. That means overnight, day and night care. So for anywhere from 2 nights up to 2 weeks, a person could stay living with dementia. That way, care partner gets a break. The local health integrated network, the Home and Community Care Division, is still doing assessments for things like bathing and dressing aid in the home. And there is in Brampton, a Brampton Seniors Task Force that will assign a volunteer to do grocery shopping, medication pickup, and errands. So that is one of the COVID services that have surfaced. The Good Neighbors Project that serves the Greater Toronto Area, including Mississauga, has a task force of volunteers on standby to offer assistance with delivering those same things, supplies, medications, groceries, that sort of thing. And then for meals, there is Meals on Wheels for Brampton and Meals on Wheels for Mississauga. It's the Victorian Order of Nurses, or VON, that runs Meals on Wheels in Mississauga. And then there's also a couple of other options other than Meals on Wheels that also do food delivery where the meal's already prepared, like Meals on Wheels. So Heart to Home and Langer Siva meal and support services. So these are some companies that are still working and serving during COVID. So you can still send in a new referral if you've never used the service before. And here's some phone numbers for areas across Peel that you can use. And then for medication compliance. This can be a big issue, especially if the person living with dementia lives alone. So one of the things that can happen is blister packing. This is where the pharmacist or pharmacy that you use would put the medication into little foil packets and lay out whether it's morning, afternoon. It's got lovely little, as you can see in the picture, it's got lovely little sun for daytime, and midday a high sun, and then for nighttime it's got a moon. So it just gives the person, you know, some visuals of when to take this medication. Now that will probably work, you know, early stage dementia, but it might not work mid stage or beyond. And so there's also Spectre TelCheck seniors program that can be set up. They're still running during COVID as well. And they will call the person to take their medication. And this is also a good service because it works a little bit like a check-in too. So if they were calling and calling, couldn't get a hold of the person, or they were talking to the person and they're asking how the person's doing and things don't sound like they're going very well, then the Spectre TelCheck would also get a hold of the person's emergency contact to notify concern. So that's another thing that can be great about that service. So for the care partners, obviously during COVID, stress levels, depression levels, things like that for care partners, caregivers of people living with dementia can be on the rise. So wanted you all to know that there are some support groups that you can recommend or that you can give them the links for so that they can access some supports for themselves while they're going through both COVID and caregiving for a person living with dementia. Because these two things together now, you know, it adds a new complexity and a new level of stress in an already stressful journey. So one is the Care Partner Cafe, which is offered through the Alzheimer Society chapters in the whole Greater Toronto Area. They all have these virtual support groups for caregivers. Most chapters refer to it as the Care Partner Cafe. So for Peel, you would just have them call any phone number of ours and go to extension 307, which is service access, and leave a message just saying the person is interested in joining a support group, and they'll be connected. Baycrest also has a online caregiver support group, and so the link for that is here. And also the Reitman Center at Mount Sinai also has an online dementia support group. And so that's at the dementiacarers.ca website. And so these links can be handed out and given, and we don't want any of these care partners to feel that they have been left alone in this scenario and during where we have to do everything virtually. There are some options. So that concludes this section of the dementia during COVID. And hopefully some of this information will assist you in your work, working with family caregivers, care partners, and also just in your own work of how to communicate in a virtual world with someone living with dementia. So thank you for joining, and hopefully we see you soon.